Previously, we discussed the bony pelvis and its role as a stout, bony intermediary between the trunk and the legs. In this section, we will discuss the muscles of the pelvis and how they function. I remain Carlos Andres Suarez-Quian, the author and narrator of this lecture. I start by listing the objectives. As before, I will not read them now. Instead, I will use these as headings of the slides to come. I presented this slide in the previous lecture when describing the bony pelvis. I remind you what the name pelvis means in Latin. It means basin. And herein is the problem with the bony pelvis. By itself, it is a rather leaky basin. It has no bottom nor sides. Well, we know this is not true in real life. The pelvis is quite competent in maintaining our insides where they belong. So, let's examine the soft tissues of the pelvis and see what comprises the floor and the sides to make this a quite competent basin. A very common approach to reveal the floor and lateral walls of the pelvis is to look at the cadaver from the back as I am showing here. The image is of a female gluteal region. For orientation purposes, I am labeling the anus and the vagina in the cadaver. These are midline structures of the pelvis, and it is a good idea to focus on the location of these structures. Indeed, a principal function of the pelvic floor is to serve as an anchor for these two organs to help them function properly and to keep them in their proper place. We will go into much more detail about these structures when we study the perineum, but for now, they serve as a landmark of the midline pelvis and will help us with the orientation. If the skin and superficial fascia of the cadaver are removed, we reveal the large muscle found on our posterior pelvis, the gluteus maximus. These are truly muscles of the lower limb, but take their origin from the pelvis and hence are required to be dissected to reach the pelvic floor. They do not serve as muscles of the pelvic floor or lateral walls. In this dissection, however, we do observe significant fatty content just lateral to the anus. This fatty content forms the bulk of the ischial-anal fossa, which is covering the muscle layer forming the pelvic floor. If the gluteus maximus muscle is reflected, we begin to see structures that contribute to the stability of the bony pelvis, the sacral tuberous ligament. And remember what this ligament did to the geometry of the bony pelvis? It helped form the greater sciatic foramen, and it's through this foramen that we first observed a muscle that begins to fill in the holes of the bony pelvis. This muscle is the piriformis, so called for its shape. Also note some nerves, the sciatic nerve in particular. We mentioned previously that nerves exit the pelvis and help to regulate the muscles of the lower limb. This is an example of one of those nerves. Moreover, the piriformis, although located in the pelvis, is actually a muscle that helps laterally rotate the lower limb, as when a ballerina steps into the second position. We will discuss these actions and many more when we study the limbs. After removing the fatty content, we now observe the space of the ischial-anal fossa, in part because we also reflected the sacral tuberous ligament. And it is at this point that we first observe the pelvic floor. There are two walls to the ischial-anal fossa. The medial wall is the levator ani and represents a principal muscle of the pelvic floor. The lateral wall is formed by the obturator internus, and its fascia actually gives rise to the levator ani. Let's look at the pelvic floor in more detail and try to gain an understanding of how it is formed, in part from the fascia of the obturator internis muscle. We understand that the three-dimensionality of the pelvis is hard to grasp at first blush. You need to look at it again, and look at it some more. I remember when I was first starting, I would use an articulated pelvis with its ligaments to keep my orientation straight. Even when dissecting a cadaver, I strongly recommend you use a pelvis during your dissection to keep oriented. But look at this drawing of the pelvis as shown from below and try to compare what you see with the dissection images. First, recognize what is the anterior and what is the posterior on the pelvis. And now realize that you're looking at the inferior view of the pelvic floor, precisely what the dissection was showing, except it is now a simplified drawing. And what are your reference points in the midline? The anus, vagina, and now we can also see the urethral opening. The male cadaver will present almost identically, but for brevity is not shown here. Basically, the same image could be used to demonstrate the male, but simply make the vagina disappear. And now we can truly appreciate the muscles as they fill in the pelvic floor and meet in the midline to support the openings of the pelvic organs. Anteriorly, we have the levator ani, one on each side, and they help to create a funnel-shaped structure known as a pelvic diaphragm. However, many anatomy books will further subdivide the levator ani into an additional division, the puborectalis, as well as other divisions that I will not name here. The reason for this is that the puborectalis portion of the levator ani will relax during defecation, allowing a straight passageway between the rectum and the anus. Of course, imagine what will happen in the absence of this muscle. This results in fecal incontinence, sometimes an outcome of a parturition in which there were complications and the levator ani was damaged. The last muscle proper to form part of the pelvic floor is the coccygeus. This muscle is not labeled in the slide. As a review, we can now provide the specific answer to the question raised as an objective. What is the function of the pelvic floor and the two major muscles that comprise it? And now, note that both the inferior and superior views of the pelvic floor are being shown in the slide. The function of the pelvic floor is threefold. It provides a midline anchor for the reproductive and excretory organs in the female and the male. It helps maintain urinary continence by providing support to the bladder. In addition, the puborectalis portion of the levator ani helps to maintain fecal continence. I should mention, however, that urinary and fecal incontinence are rarely issues for the male. Remember, the male pelvic floor is not challenged by parturition. Usually, it would be trauma that injures the male pelvic floor that would result in urinary and/or fecal incontinence. And the muscles you need to know are two: the levator ani and the coccygeus. There's a special feature of the levator ani, however, that you should become aware of as it pertains to the pelvic floor. Note that most of its origin is from the tendinous arch, the thickening of the obturator fascia extending from the body of the pubis to the ischial spine. Understand why the way that the levator ani takes its origin from this tendinous arch and extends to meet its contralateral levator ani, originating from the opposite side, prevents the anatomist from seeing the bottom of the pelvis from the top. The presence of the levator ani across the pelvic floor often confuses students looking simply at images of the pelvis if they have not dissected and held a pelvis in their hands. If you ever have a chance to look at the pelvic floor from its superior view, you will observe and gain a significant appreciation on how the integrity of the pelvic floor depends indirectly but to a large part on this tendinous arch. We now turn to the subject of muscle innervation, and for once, the nomenclature is straightforward. Each muscle is innervated by its namesake nerve. For example, the levator ani is innervated by the nerve to the levator ani, the obturator internus muscle by the nerve to the obturator internus muscle, etc. Let's take a look at these nerves now that originate from the sacral and coccygeal plexuses. For orientation purposes, the sacrum and pubic symphysis are labeled, as is the psoas major. Now we identify some of the muscles we have been discussing in this lecture. The levator ani, taking its origin from the tendinous arch of the fascia of the obturator internus. And finally, the coccygeus and the piriformis. We now identify nerves we may have seen previously when we studied the abdomen, the obturator nerve and the lumbosacral trunk, consisting of L4 and L5. And now we finally identify the component to the sacral plexus. The large nerve diving deep through the greater sciatic foramen is the sciatic nerve, comprised of the lumbosacral trunk and S1 to S3 components of the sacral plexus. To finish up with the sacral and coccygeal plexuses, let's look at a drawing of these plexuses. The sacral plexus consists of L4 to S4 nerves, and the coccygeal plexus refers to the S5 coccygeal nerve and the anococcygeal nerve. We also see that I have used two colors to represent the nerves of both plexuses. This is because the nerves arising from these plexuses are formed by dorsal and ventral divisions of the corresponding spinal nerves. The dorsal divisions are indicated in yellow and the ventral divisions in red. The nerves to the four muscles we just discussed are now indicated in the slide as to their location within the sacral and coccygeal plexuses. Clearly, there are many more nerves present in this plexus. Many of these nerves go on to innervate the muscles of the lower limb. Some, however, do work on the pelvis, and we will explore these nerves in a later part of this lecture. This now concludes the presentation on the muscles of the pelvis.